I would like to present here mostly with the images of 3D printed models. Looking at the literature, this is the first description on the morphology of double aortic right ventricle. It was 1764, whose name is John Abernethy. So I Googled who he is, and then I found this book, and then I bought this book $600. See, 1764, and then I was able to find the drawing, beautiful drawing of double aortic right ventricle. So this is open right ventricle. You have pulmonary outflow tract, aortic outflow tract, and ventricular septal defect immediately below the aortic valve. So double aortic right ventricle with the subaortic VSD, very, very nicely illustrated. So dealing with the morphology of double aortic right ventricle, we often ask, are the diagnosis of tetralogy of Fallot and double aortic right ventricle mutually exclusive? The second frequent question is that, is bilateral infundibulum or conus an essential feature of double aortic right ventricle? And third is, what is really Tausig-Bing malformation? And does absence of the outlet or infundibular septum characterize the doubly committed ventricular septal defect in DORV? And then how is the remote VSD defined? And how is the restrictive VSD defined? So all of these are very frequently asked questions, so I try to tailor my presentation to answer the questions. So double aortic right ventricle, what's in the name? Is it really the disease entity? It's not. It's not a specific pathologic entity. That should be understood first. It is a form of ventricular arterial connection. It's a descriptive term for simply how ventricle connects to great arteries. As you know, that the ventricular arterial connection, you have multiple different the types. This is a concurrent VA connection, RV to PA and LV to aorta is normal. And then you can have RV to aorta and LV to PA. This is a discordant connection, which we usually call transposition. And then this is double aortic right ventricle, this is double aortic left ventricle, so forth. So in that regard, double aortic right ventricle is simply one form of ventricular arterial connection. To define that, because there can be a concurrent and discordant connection versus double aortic right ventricle, we need to have a certain criteria. So usually use that 50% override the rule. So this is not really functional classification, but this is for the registry or any way you need to divide into two. So be sure that the 50% actually is more formality rather than real surgical or functional significance. Anyway, double aortic right ventricle we define again as one form of ventricular arterial connection in which more than half of both arterial trunks arise from the morphological right ventricle. So that's it. So to do so, let's revisit the terminology again. So yesterday we discussed a little bit. I will quickly go over again. So here is this normal right ventricle opened, normal left ventricle opened. So here in the right ventricle, there is discontinuity between the tricuspid and pulmonary valve. And then here, there is continuity between the aortic and mitral valve. The reason why there is discontinuity and continuity is the fact that there is a crista supraventricularis in the right ventricle. There is no crista supraventricularis in the right ventricle. More precisely, there is no VIF here. There is a ventricular infundibular fold. There isn't ventricular infundibular fold. So when you have your ventricular infundibular fold or crista supraventricularis, the ventricular outflow tract is completely muscular funnel. So therefore, this is called infundibulum or conus, while if there isn't the ventricular infundibular fold or aortomitral continuity, outflow tract is not completely muscular. So therefore, there is no the infundibulum or conus. So I emphasize again, all of these using very different terminology, actually talking about exactly the same thing. So what is crista supraventricularis? Cranially, it is a pulmonary valve. The caudally, it is tricuspid valve. Between these valves, because of this continuity, there's a muscular crest between these two valves. And then, if you look at this carefully, it is something like an inverted V configuration, and the Boston group called this is a parietal band and this is septal band. However, the Europeans usually call this is ventricular infundibular fold, which is a parietal side. This is trabecular septum marginalis. In the trabecular septum marginalis, in between, there is the outlet septum here. To make it a little bit more clear, trabecular septum marginalis is a Y-shaped configuration. Body is here, going toward the apex, anterior limb toward the pulmonary valve, and posterior limb toward the apex of the tricuspid valve. It is a Y-shaped configuration. Tricuspid valve, this is a septal leaflet of the tricuspid valve. This is anterior-superior leaflet of the tricuspid valve. This is posterior-inferior leaflet of the tricuspid valve. These two valves give rise to coda tendinae to make an insertion to this small nipple-like papillary muscle, which is called the medial papillary muscle of Lancisi. So if it is more cranial to this medial papillary muscle of Lancisi, in looking at the specimen, or in the surgical field, surgeon's left-hand side, this is called outlet septum or corner septum. So membranous septum is behind that at the apex of the tricuspid valve. Okay. So this is a drawing of the normal right and left ventricle. So dividing that tricuspid valve, pulmonary valve, inner septum, apical trabecular septum, outlet septum here. In the left ventricle side, the same. If we have a VSD in this location, because membranous septum is around, it is called the perimembranous ventricular septal defect. The defect can be a little bit more cranial, away from the membranous septum, and then the type of VSD is called muscular outlet VSD. And then the VSD can be more cranial immediately below the pulmonary valve, and then this is committed to both arterial valves. That is why it is called a doubly committed ventricular septal defect. From the right ventricle side, they are a little bit wider apart, but from the left ventricle side, they are all close together immediately below the aortic valve. All are subaortic VSDs. These are most common types of VSDs in double aortic right ventricle. However, those are not the exclusive type of ventricular septal defect in double aortic right ventricle. So to define the double aortic right ventricle, to describe the morphology of double aortic right ventricle, we have a couple of terminologies. Because the left ventricle does not have any outlet, VSD is almost always present. There are only a bunch of cases reported, VSD is completely closed, but however, most of the time we have VSD, and VSD is the only outlet of the left ventricle. And the right ventricle, there are two outlets, the subaortic outflow tract, pulmonary outflow tract. They are divided by outlet septum. Normally, outlet septum was interventricular structure. However, in the double aortic right ventricle, outlet septum is exclusively a right ventricular structure in double aortic right ventricle. There are debates on the presence of the ventricular infundibular fold. Initially, in 1960s and 70s, the pathologists looked at the heart and found that most of the DORV cases have bilateral infundibulum with the ventricular infundibular fold present between the semilunar valve and atrioventricular valve. So that's why they described very distinctly about bilateral, the infundibulum characterizes the DORV. However, subsequently, many people recognize that the double aortic right ventricle can be present without having muscular infundibulum. So the other people also call conus. Conus and infundibulum are almost identical synonyms. Okay. So classification of the double aortic right ventricle is rather simple. What happened is that if the VSD is here, surgeon can simply patch the VSD in this way, if the VSD is below the pulmonary valve and then patch here and do the arterial switch operation, etc. So if the classification gives this kind of insight into the surgical implication, and then it will be very, very beneficial. So if we think about the surgical options in the double aortic right ventricle, the first is a simple tunnel repair. And then the second is that the tunnel repair with arterial switch operation. And if here the arterial switch operation is not feasible, and then you can do the Nikaido operation with the tunnel, and then Rastelli or REB operation with tunnel. And then if here those biventricular repair is not possible, you can do 1.5 repair or complete the Fontaine pathway. To the decision between this biventricular repair and this 1.5 or univentricular repair is very, very important. That's why the diagnosis of double aortic right ventricle is so important. In making the decision for surgical the plan, whether we can do the biventricular repair without any inlet or outlet obstruction, and then whether we don't harm any vessels, so we keep all the valves competent, and the coronary perfusion should be perfect, and then adequate ventricular volumes can be maintained. So all of this should be questioned. So this is the very, very classic left classification, which was introduced in 1972, which we still use. And here you have your subaortic VSD, subpulmonary VSD, doubly committed VSD, and then this is remote VSD. Although that this is very informative, often we find that it is very difficult to categorize any case into one or the other type. Often difficult. So in this model, you can see open right atrium, right ventricle, aortic outflow tract, pulmonary outflow tract. VSD is immediately below the aortic valve here. Here, immediately below the pulmonary valve. Below the aortic and pulmonary valve. Aortic valve is here, pulmonary valve is here. This is a AVSD, rather remote from the arterial valves. So this is the pretty 3D and the drawing correlation. In doing so, we need to look at these 5 variables all the time. The first is that define the VSD within the ventricular septum, which means that whether it is inlet, trabecular, or outlet. The second is the perimembranous or non-perimembranous. Perimembranous or non-perimembranous is not academical interest, but more for some insight into conduction axis. And the third is orientation of the outlet septum. And fourth is extent of the muscular infundibulum, and then also great arterial relationship. So here, these drawings and the samples are all having sinusolytus levocardia with aorta on the right side of the pulmonary trunk. So, however, you can have all the other variations. Anyway, if you look at the VSD here and here, they are not very different. They are in the outlet part. Here, what is different is that the outlet septum, infundibular septum, is to the left margin of the VSD, isolating this VSD from the pulmonary trunk exclusively committed to the aortic valve. Here, outlet septum is on the other side of the VSD, to the right margin of the VSD, isolating this VSD from the aorta, but immediately below the pulmonary trunk. So that's what I mean here. Orientation of the outlet septum relative to the VSD margin is important. Okay, so what is the perimembranous and non-perimembranous? These two cases, you have here the VSD at the top of the tricuspid valve here. So tricuspid valve is here, VSD is a little bit away from the tricuspid valve. On your left side, conduction axis will be immediately here. Therefore, surgeon needs to be careful in touching this margin. However, in this case, conduction is away from the VSD margin, and the surgeon will have freedom to touch the VSD margin. That is the significance of perimembranous versus the non-perimembranous. So here is another case. Here, this VSD the aortic valve is very close. However, this VSD is half outlet, half inlet. It's not completely inlet. Why? How do I know? This is the medial papillary muscle of lenses in the middle, so therefore this is confluent outlet and trabecular extended, inlet extended VSD. However, the distance between the aortic valve and VSD is very large. Why is that? Here you have a stout, very long subaortic infundibulum, while here there isn't any subaortic infundibulum. So that's what I mean, that extent of muscular infundibulum is also important in describing the pathology of VSD. In terms of great arterial relationship, this is the subaortic defect and this is subpulmonary defect. I simply flip the aorta and pulmonary trunk like this. Okay? And then with the same internal cardiac anatomy, all of a sudden this VSD becomes subpulmonary, and all of a sudden this becomes subaortic as contrast to usual cases. Therefore, we also always need to know the great arterial relationship. So with this declassification, the literature, I collected about 10, 20 papers together, and then I find that the cases reported 50% have subaortic VSD, approximately 25% has subpulmonary VSD, and then non-committed VSD, there is wide variation, 5 to 25%, altogether around 20%. Doubly committed VSD, 3 to 10%, and just 5%. Okay. So this is the example of the so-called normally related great artery, double artery right ventricle. VSD is below the aortic valve here. So this is the double artery right ventricle with subaortic VSD. This is the double artery right ventricle, but the VSD is immediately below the pulmonary valve. Pulmonary valve is overriding. So this is typical subaortic VSD. This is subpulmonary VSD. Inside of the heart, this is the case. So this is the tricuspid valve leaflet, and this is right ventricle, aortic, and pulmonary outflow tract. Infundibular septum is here, isolating VSD from the pulmonary valve, so therefore subaortic VSD. Here, infundibular septum is to the right margin of the VSD, therefore this outlet VSD is below the pulmonary valve. So those are the very classic cases. So if you look at this VSD from the apex, this is the basal view. You are in the apex of the right and left ventricle. So this is a right ventricle, this is a left ventricle, tricuspid valve, mitral valve, aortic outflow tract, pulmonary outflow tract, infundibular septum is here, toward the right margin of the VSD. However, in this case, a little bit different. So it is a very similar disease. The right ventricle gives rise to anterior aorta, and behind that there is a pulmonary outflow tract, and then VSD is here. I cut the apex out and looking at the base of the ventricle from the apex, and then this is the left ventricle, this is the right ventricle, and then aorta is exclusive from the right ventricle. Approximately 60% of the pulmonary valve is from the right ventricle, and this is outlet septum. If you look at the outlet septum here, this is interventricular septum, outlet septum. This outlet septum doesn't go to the VSD margin. It's simply parallel. So in terms of pulmonary outflow tract here, so there are two different types of subpulmonary defect. Here, infundibular septum is vertical to the rest of the ventricular septum. So therefore, this infundibular septum is fused to the right margin of the VSD. Here, the VSD is here, outlet septum is parallel. What it means is that this is the drawing of complete transposition, and then if you rotate the great arterial trunk and push the pulmonary valve clockwise, and pulmonary valve will come here, and then VSD will be remaining here. This is the infundibular septum, fused to the right margin of the VSD. However, this is a little bit different. Instead of a rotation, if you push the pulmonary valve and aortic valve all forward, and then everything will be pushed forward. So therefore, infundibular septum is parallel with the VSD margin. Okay? So defining all of this will be certainly have some surgical implication. So this is a classic atrioventricular septal defect, which is quite far away from the aortic and pulmonary valve. But however, infundibulous septum is here. Certainly this remote VSD is closer to the aortic valve and possibly baffleable to the aorta. Okay? So this is another DORV with VSD rather restrictive. And then inside of the heart, this is a right atrium, right ventricle. This is aorta. This is an infundibulous septum. Below there, you have the pulmonary outflow tract. VSD is a perimembranous, rather small, quite far away from the aortic valve. Okay. So in terms of remoteness, we need to define when we really call remote. Look at the distance from the upper margin of the VSD to the closest semilunar valve. Measure the distance, and if this distance is larger than the semilunar valve diameter, which should be age-matched, that is the definition of remote VSD. So here that you can see the VSD is here, very remote from here, very remote from the pulmonary valve. However, that definition sometimes is tricky. So how many people will call this VSD really remote? Dr. Prakash, would you call this case that a remote VSD or here? Or subaortic VSD? Subaortic? Yeah. So however, the little bit difference is that this is a half outlet, half inlet VSD. Okay? So the distance here is a little bit more than the aortic valve diameter and probably a little bit more than the age-matched semilunar valve diameter. By that definition, it is subaortic. How this remote. However, is it really reasonable to call this remote? Not really. The reason why is that in the remote VSD, there are cases certainly baffleable to the aortic outflow tract, and there are cases baffleable to the pulmonary outflow tract, and then like the case I showed you prior, the first case, and then really remote. So those are very important because that without thinking baffleability to aortic or pulmonary valve, the patient can be on the track of Fontan operation and unnecessarily exposed to all complications of Fontan. So the lesser classification of remote VSD is very, very important. So that's why the non-committed VSD here, I shaded. So a lot of cases actually surgically subaortic and a lot of cases actually subpulmonary. Real non-committed will be rather small number of cases. So this is the example. So this is the open right atrium and right ventricle. You have ventricular septal defect. This is subaortic outflow to subpulmonary outflow, and then VSD seen from the left ventricle. However, if you rotate it, this VSD certainly is remote, is far away, and then infundibulous septum is here. No question it is remote VSD. However, it is likely to be baffleable to the aorta because VSD is here, and then this is the infundibulous septum. If we patch it from here, there will be a left ventricle to aortic connection, and then RV to PA connection. Actually, before we have 3D printed motors, all agree that we should go for univentricular repair. But after surgeon had the motor in hands, he decided to do the biventricular repair after removal of infundibulous septum like this. So this is a surgeon's view. Dr. Prakash will be sitting here, and then this is a left atrium, this is a right atrium. You have the atrial septal defect. This is a tricuspid valve, and this is a subaortic outflow tract, so pulmonary outflow tract, deviated outlet septum here. So there was this muscle bundle here. So surgeon decided to remove this and then shave out the muscle bundle around here, and then do the biventricular repair. And then actually, this is really the model. I provide the surgeon, and then surgeon did the appropriate surgery, and the patient is now having 2 ventricular circulation. Okay. So here you have the ventricular septal defect, certainly in the outlet, and then below the aortic and the pulmonary valve. Okay, so doubly committed. However, this patient certainly has infundibulous septum here. Okay, so here in the basal view, this is the left ventricle, right ventricle, VSD, doubly committed, infundibular septum is there. So doubly committed VSD, there are cases actually having infundibular septum on the top of the VSD. So, and then otherwise, this is another case. This is the right atrium, right ventricle. You have aortic valve and pulmonary valve. Actually, there is no infundibular septum. However, VSD is not doubly committed. VSD is below the aortic valve only. So which means that presence or absence of infundibular septum is usually in concordance with the doubly committed or non-doubly committed VSD, but not necessarily. Absence or presence of outlet septum does not necessarily characterize a doubly committed VSD. That is an important thing that you should remember. Okay. So in the pathology, so this is a classic doubly committed. My pathologically done pairing gave me these slides. So this is open right ventricle. So this is the aortic outflow tract. This is pulmonary outflow tract. This is the junction between the aortic valve and pulmonary valve. There isn't any infundibular septum. However, VSD is exclusively below the aortic valves. Absence of infundibular septum did not characterize this VSD as doubly committed. On the contrary, this case, this is the tricuspid valve, open right ventricle, and this is the aortic outflow tract, this is pulmonary outflow, right and left pulmonary arteries. VSD is below the pulmonary valve. There is no infundibular septum. Okay? So actually, those the subaortic VSD is more common than real doubly committed, which means that real doubly committed is very, very, very rare. Okay, so going back to this drawing, the surgeons didn't like LABS classification, and then especially in European societies, they try to classify the VSD in DORV in such a way. So VSD type, if there is a narrowing, called tetralogy fallow type, TGA type, or non-committed type. So having the classification like this, have a surgical, the idea of what to do. Associated abnormalities in DORV include the juxtaposition of the atrial appendages and straddling and overriding aortic valve and ventricular outflow tract stenosis, either subaortic or subpulmonary, and obstructive lesion of the aortic arch. And then this is the pathogenesis of duct juxtaposition. So this is the straight heart tube, D-looping or L-looping. After looping, what you need to have is that inlet should move to the right, and then outlet should move to the left. Therefore, atrium is embracing the rest of the heart from behind. However, if this process is deficient, outflow tract remains in the right ventricle. Therefore, there is a higher incidence of juxtaposition of the atrial appendages. Okay. So ventricular outflow tract obstruction, this is a cartoon of subaortic VSD, this is a cartoon of subpulmonary VSD. The way how it happens is that it is starting from normal heart. This outlet septum is the opening the door toward the left side of the patient, and then opening the door to here, you have your door here, the opening here, and this area can have obstruction. Here, starting point is complete transposition. Door is open toward the aorta, so therefore subaortic stenosis is common in this situation. So this is the case with the subaortic VSD with this subpulmonary obstruction. This is the subpulmonary VSD with the subaortic obstruction. Okay, let me skip this one. One more thing is a straddling mitral valve. So this is the cartoon of the double aortic right ventricle with the subpulmonary VSD seen from above. This is the right side, left side, posterior anterior, aortic valve right anterior, pulmonary valve a little bit to the left and posterior. So how it happened is that actually infundibular septum is moving backward, therefore making pulmonary valve within the right ventricle, and then VSD is below the pulmonary valve. If we have this deviation a little bit more, and you will have this, mitral valve is now beginning to straddle. Okay, so that's how that in DORV with the subpulmonary VSD, mitral valve straddling can happen. And that is usually through the anterior VSD rather than posterior VSD, which makes the tricuspid valve straddling. Okay. Okay, let me come back to the frequently asked questions. Are TOF and DORV mutually exclusive diagnosis? So this is a classic tetralogy fellow with the subaortic VSD. However, that definition is why. There is a leftward anterior and superior deviation of the outlet septum, and then there is a model alignment to VSD. That is the morphology of the outflow tract and VSD. That makes the diagnosis of VSD. However, if you look at this basal diagram, here the view here, this is the left ventricle, this is the right ventricle. Both aorta and pulmonary trunk arise from the right ventricle. In terms of ventricular arterial connection, it is the double aortic right ventricle. So you have both the entities existing in the same patient. Therefore, this case can be easily called TOF with a double aortic right ventricle or TOF type of double aortic right ventricle. So which means that TOF and double aortic right ventricle can coexist. So what is Tausig-Bing malformation? This cartoon is the original Tausig-Bing malformation. What it is, aorta arises entirely from the RV, and then pulmonary orifice overrides the ventricular septum, and then there are bilateral infundibulum, and then side-by-side relationship of the great arteries. It is a single case report. There are not many cases in the original paper, which is 1949. Subsequently, in 1966, Dr. Lev, who made the DORV classification, extended the definition of double aortic right ventricle to include actually complete transposition. So then there was a lot of confusion how we define the Tausig-Bing malformation. However, most of the people, they define Tausig-Bing malformation with the DORV with the subpulmonary VSD. So therefore, there is some controversy in the terminology of Tausig-Bing malformation. It's not surprising that in the literature, statistics all vary according to how they define the Tausig-Bing malformation. Is bilateral infundibulum an essential feature of double aortic right ventricle? We already discussed, no. Okay. In summary, double aortic right ventricle is not a pathologic entity. It is only a descriptive form of ventricular arterial connection with more than half of both arterial trunks arising from the morphological right ventricle. When we look at the DORV, we need to look at all these five issues: VSD location within the septum, perimembranous or non-perimembranous VSD, orientation of the outlet septum relative to the VSD margin, extent of the muscular infundibulum, and great arterial relationship. And then also we need to describe the anatomical issues of surgical importance, which is again location of the VSD, expected course of atrioventricular conduction axis, extent of direct contact of tricuspid valve to the VSD margin, and extent of muscular infundibulum, and space between the tricuspid valve and the pulmonary or aortic valve, and then caudal insertion of the tricuspid valve to the outlet septum. Thank you very much for your attention.